Hi class, it's Kelly Albozic. Just wanted to offer you guys a voiceover PowerPoint for musculoskeletal, so we'll get going on that. So again, readings, all in Ricky chapter 44. Sprains, fractures, casting and traction, scoliosis, developmental dysplasia of the hip, and clubfoot. So the first thing we're going to go over is sprains. So sprains result from a twisting or turning motion of the affected body part. Typically, we have sprains occurring in our ankles. That's kind of the most common area. What happens is the tendons and ligaments stretch. They stretch excessively, and sometimes they may even tear. They can be uncommon in young children, which to the reason being is that their growth plates are weaker than their muscles and tendons. So actually children are actually more prone to fractures than they are to sprains. Sprains can occur at any joint. Like I said, ankles are very typical, knee joints, wrists. So nursing assessments for a sprain. So kind of getting a good idea of how this injury occurred. Get a good health history. Was this a sports injury? Was it a contact injury? Has the family or patient used any treatment so far? So did they put ice on the affected extremity? Did they give the patient maybe some Tylenol or ibuprofen? Did they elevate the limb? Did they put any compression on the limb? And you want to inspect the affected body part. So we're looking for swelling, we're looking for any bruising or color changes, and deformity, which would be a little bit more concern for a possible fracture. I can't say this enough, and we're going to be talking a lot about this, but CSM. So how is the neurovascular status? So we want to look at the color of the affected area. Are we getting good blood flow? Is the limb pink, or is it kind of pale and blue? How are the pulses? Hopefully we do have active positive pulses. How's the temperature? Is the skin warm or is it cold? Can the patient feel you touching them? How's their sensation? Check if the patient can bear weight on the affected joint. Are they limping? Definitely do not perform any passive range of motion on the affected extremity. And I know we've all heard this before, but the acronym RICE, but it stands true. So rest, ice, compress, and elevate. So we want to rest and limit any activity. We want to ice the affected area, and I know we talked about this in class, but we want to apply cold packs for at least 20 to 30 minutes, and then remove for an hour, and then repeat that cycle. Compression, so applying ACE wraps to the area, elastic bandages, or even a brace. Always making sure that you check for skin integrity when unwrapping and rewrapping the extremity. And the last one is elevation. So we want to elevate that extremity above the level of the heart to decrease any swelling. The nurse may even need to instruct the family, especially if the patient or child may need crutches. So doing a little education on the use of crutches. And also how to prevent sprains in the near future, especially if it was a sports-related injury. Just making sure that they know, the child needs to adequately warm up, do proper stretching, things like that. And then that is just a video on, the mechanics of a sprain. All right, so moving on to fractures. So this actually occurs more frequently in children, like we had mentioned earlier. Common sites for fractures in children are the forearm and the wrist. And most PD fractures heal very well with minimal treatment. Their bones are still very flexible and they're still growing, and that's a positive for the child because typically fractures will heal a lot quicker the younger the child is. Fractures typically occur from accidental traumas, falling, maybe a sports injury, but we need to also keep in mind that there are non-accidental forms of fractures, and we should always have that concern for possible child abuse in the back of our mind. we need to be aware that, especially if an infant or a baby does have a fracture, especially before the age of walking, um, we really need to take in consideration on the history of the fracture and how that happened. That should raise a concern. Also, trauma at birth, very typical for infants. Midclavicular, humerus, and femur fractures can happen. And I know in class I talked about my newborn son's recent fracture when he was born. He did have a midclavicular fracture as he was born. So some babies need splinting and immobilizing, especially when talking about fractures at birth. But infants' bones are so flexible and so easily to heal that a lot of times they don't even need splinting or immobilization, little or no intervention. And for example, like Clayton, you wouldn't even know that he had a midclavicular fracture, and he never needed splinting or immobilization. And just a picture of a newborn with their midclavicular fracture. It looks like it's on the left side. So the pathophys behind a fracture. So I asked in class, what is the most vulnerable portion of the child's bone, and frequently the site of injury, and that would be the growth plate or around the growth plate. And we're going to talk about that. There's a Salter-Harris classification system, and that's used to describe fractures involving the growth plate. So we'll get into that in the next few slides. So children who typically have a thicker, more elastic periosteum, which actually yields to the force encountered with trauma, end up with non-displaced fractures. So a non-displaced fracture occurs when the bone cracks, but it maintains its proper position and alignment. Children who have increased vascularity and decreased mineral content, may end up with plastic or bowing deformities, as well as buckle and green stick fractures. And complete fractures can occur in children, but they tend to be more stable than if they were to happen in an adult. And a complete fracture is actually just a complete break. The bone breaks in actually two parts. Spiral, pelvic, and hip fractures are very rare in peds. And just a little reminder, A and P, because we're talking about the growth plate here. So the growth plate is known as the physis. And then the end of our bone, epiphysis. And then right below the growth plate leading into the diaphysis is the metaphysis. So with the Salter-Harris classification, we're going to be looking at the parts of the bone that has to do with the growth plate, the epi, and the meta. And here is our mnemonic, our Salter-Harris classification. So at the left-hand side of your screen, you see a normal bone with a normal growth plate, no fracture whatsoever. And then there's type 1. So type 1 is the acronym S, meaning straight across. So the fracture actually happened straight across the growth plate. Type 2 is above the growth plate, and that is in the meta area, right? So here's the meta going into the growth plate. Type 3 is below the growth plate or lower as an L, and that is epiphysis going into the growth plate. Type 4, TE, is through everything, okay? The meta, the physis, the epi. And then type 5 is actually just a crushing injury with a mnemonic of R. And just some pictures of examples of types of fractures. So this one on the far left here is plastic or bowing, and I know someone mentioned in class that you see this in rickets. So there's significant bending of the bone but without breakage. Um, this fracture in the middle of the screen is actually an incomplete fracture, so that would be known as a green stick. You can see that is cracked, but it's not completely broken in half, okay? The upper right-hand side is complete, the bone broke into two pieces. And on the bottom here, we have examples of what is called a buccal fracture. So it's actually a compression injury. The bone buckles rather than breaking. Okay. Complications of fractures. So plastic deformity in the Seltzer-Harris type 5 fractures can result in angular deformities. So remember, the type 5 fracture is actually that crushing fracture. Okay. Um, Infection can happen, avascular necrosis, and I know we went over in class, avascular necrosis is actually the death of a bone tissue due to lack of blood supply. Lack of blood supply. Bone shortening can happen, vascular or nerve injuries. We did talk about fat embolism, so that happens typically in more long bones that break, like a femur or your tibia, and it's actually a piece of intravascular fat that actually comes out when your long bone breaks. It goes into your circulation and it lodges itself into a blood vessel, causes blockage of blood flow. Sometimes it can go right to your lungs or your heart, which is a huge medical emergency. And then compartment syndrome, which we're actually going to talk about in a few slides. So management of fractures. So, we're very familiar with casting, and casting is performed to provide further comfort for the child and to allow for increased activity while the fracture is healing. Sometimes, in children, casting may not even be, part of the process. They might just let the bone heal on its own. But if the bone does need reduction, or the child needs a little bit more comfort, or they can use a little bit of increased activity, they will probably put a cast on the area. Displaced fractures do require manual traction to align the bones, followed by casting. An open reduction and internal fixation. Okay, so this is actually surgery. So open reduction, they're doing surgery, they're going in, fixing what is broken. And internal fixation. So they're kind of placing pins and screws and maybe plates. Then we have external fixation, which is surgery again, but there's actually an external device, which is the picture to the right, helping heal the bone, keeping the bones in place. These are very typical for complete fractures. And we talked about why we would want to delay casting. And someone did mention that, due to inflammation. So we typically, significant swelling happens very early in the fracture. So if we give the time for swelling to subside, the cast will actually be fitted correctly. You don't want the cast to fall off. And if it's not fitted correctly and the swelling goes down, we're not going to have that correct reduction and proper healing of the bone. Nursing, so our part. So getting a good health history, physical exam, what questions would we ask the child? How did this happen? What was the trauma? What was the mechanism of injury? Was it a sports injury? Was it contact? Was there protective equipment in use? And what are we going to assess? So, can they bear weight? Are they limping? We really want to inspect the area, right? So the coloring, is it bruising already? Is it swelling? Is there any deformities? Palpate, where's the area of tenderness? And you're going to hear me say this 100 times, but doing those CSM checks are so important. So the color of the skin, is it pink or is it pale? How's the temperature? Is it cool or is it warm? Can they feel you touching them? How are their pulses? Capillary refill. Diagnostics, so typically x-rays, will do the job. Sometimes CT, MRI is needed. Immediately after the injury, we do want to immobilize the limb with a splint. We want to apply the ice to reduce swelling. And again, we want that on for 20 to 30 minutes, off for an hour, and then repeat. Elevate the injured extremity above the level of the heart. Again, frequent CSMs, assessing pain level and providing pain medication. And I know you guys told me this before, but we talked about an open fracture a little bit, and an open fracture is when the bone actually goes through the skin. So what should be administered to a child if there was an open fracture? And it was mentioned that a tetanus, if the child did not receive a booster for tetanus, they should receive a tetanus injection. And we're going to talk a little bit about compartment syndrome. So there's 5 P's to rule out any compartment syndrome. And the first one we're going to talk about is an increased pain that is not tolerable. It's out of the norm. Okay, it's not the type of pain that they've been having. So that's very dangerous. It's caused by pressure buildup from internal bleeding or swelling in the tissues. The pressure actually, what happens in compartment syndrome is the pressure actually decreases blood flow, depriving the muscles and the nerves. So this is where these symptoms come from. So there's increased pain that is not tolerable. Pulselessness, again, because of the buildup of swelling and the pressing down on the blood vessels, we're not going to get that accurate pulse to the extremity. Pale, again, we're not getting that good blood flow to the extremity. Paresthesia, so it's burning or tingling. The patient may feel like their extremity has pins and needles. And then paralysis or weakness to the affected area. This is definitely an emergency, and typically surgery is needed. All right, so casting. So we want to immobilize that bone that has been injured or diseased. So again, some fractures can heal on their own with a need of, without a need of a cast, but typically casts are preferred, especially it helps to reduce pain and it allows some more increased mobility, especially if we're dealing with adolescents. These casts hold the bone in reduction and they help prevent deformity as the fracture heals. They've been traditionally plaster. Now we have more fiberglass casts. And cast removal can be a little bit scary for the adolescent, so doing a little education with them. The cast cutter can be loud, so letting the child know what they're going to hear. It's not going to injure their skin. Maybe show them by putting the cast cutter to your palm. Also, when we're taking the cast off, it's important to educate we may see brown flaky skin. That's normal post-removal. New skin may be a little bit tender. It's good to soak the skin in warm water after the cast has been off, doing daily moisturizing lotion, encouraging, activity actually to regain activity again, and the patient may need PT afterwards. Again, just some examples of casts. So we have on the left-hand side, we have a short leg cast. In the middle is a leg cylinder cast, and then on the right of this picture is a long leg cast. Top right here is a shoulder spica cast, and this rod actually just helps support the strength of the cast to keep that arm in the proper position and proper alignment. And then these are actually long leg hip spica casts. So this is bilateral. And then one is one full leg and then a half leg. So just examples of casts. So nursing care and cast care.
So how do we reduce the child's fears? So it's actually, it's good to show them the material, let them touch the material. Um, do they have a toy that we can pretend to put a cast on, make them feel a little bit more comfortable? Using distraction. Casts come in colors now, so maybe allowing them to choose their own color. It's important to pre-medicate with pain medication. Making sure that the swelling, has decreased, so we'll have a proper fit of the cast. Doing that baseline neurovascular assessment, we want to do the baseline CSMs, because if we have anything out of the ordinary, think about the 5 Ps: increased pain, increased edema, pale or blue color, coolness. We may have a concern for compartment syndrome, right? Um, while the cast is drying, it's important to educate that the child may feel a warm sensation in the cast, and that's normal. Fiberglass casts take just a few minutes to dry. Plaster does take a lot longer. Again, we talked about neurovascular checks and CSMs. Inspect for any odor and drainage, especially if the cast has been on for, you know, a week or so, or more than just one day. We want to inspect anything for odor and drainage. Sometimes things can fall into the cast, and we want to make sure that it's free of bacteria. Elevating the extremity, applying ice is very important. Looking for the skin integrity, we want to make sure that the cast isn't rubbing on anything on the skin. Crutch education again, and having the patient wiggle their toes or fingers, look for any increased swelling. We don't want to ever insert anything into the cast. If it's itchy inside, sometimes what helps is actually blowing cool air from a hair dryer on low into the cast, but it's very important not to apply any lotions or powders inside. And we do want to protect that cast from water, so applying a plastic bag over the cast. Some new casts now come waterproof, but that's all on the discretion of, the provider and what they want to place on the patient. So traction. So this is actually a method of immobilization to reduce and immobilize a fracture, and it helps align the injured extremity. Traction can also help reduce pain, and it actually decreases any muscle spasms. So we have running traction. So this is when weight pulls directly on the extremity in one plane, and this can be done by skin or skeletal traction, and we're going to talk about that in the next few slides. And then there's balanced suspension traction. So additional weights are used to provide any counterbalance to the force of traction. So it's a pulley system. So there's a constant pull on the extremity even when the child may be changing positions. So here we have skin versus skeletal. So it pretty much states itself. It's applied to the skin via straps or tape secured with an ace bandage or even traction boots. This is a little bit more limited for length of treatment, and less force is typically used for skin traction. And then skeletal is actually traction applied. If you remember that external fixator device, the picture, we have the ropes and pulleys actually attached to the external pins that are coming out of the bones. So it allows for longer periods of treatment, and you can apply more force to skeletal traction. And then traction care and nursing care. We want to always make sure that there's appropriate application of the traction and the weights are maintained in proper alignment. We want to make sure that the ropes and pulleys are never, they're free of obstruction at all times, and the weights can move freely. If you are applying skin traction, we do want to make sure to prepare the skin with an appropriate adhesive before applying any traction tapes. And if there's any boots or ace wraps, we want to prevent any skin friction or breakdown. So it's important for the weights to hang freely.
without touching the floor. And for skeletal, we talked about that the ropes are attached to the pins on the external fixator device. Very important to provide pin care if this is a skeletal traction, and we'll talk about that. And we do want to avoid any sudden bumping or moving of the bed that'll disturb any alignment. And these are just some pictures of traction. Again, I don't expect you to know the different types of traction. I just want you to have an idea of what it is. So as you can see in many pictures, it's like a weighted pulley system, and the extremity is kept in constant, pull, and that helps with healing. The child with both of their legs up, that is called Bryant traction, and that's typically used to reduce femur fractures in children younger than 2. It can also help with developmental dysplasia of the hip. Right here in the middle top is actually a Russell traction device, and that's skin traction for femur fracture, hip, and specific knee injuries. And the portion of the weight is redistributed in the use of pulleys, as you can see, and then the weight is hanging down off the edge of the bed. There's Buck's traction, which is showing you here with the bottom left with the boot. This is typically skin traction for hip and knee contractures. There's no diversional pulleys like you see this top middle one. We have diversional pulleys up top, where Buck's traction is just that constant pulling force from that one angle, continuous line. Top right here is cervical skin traction. So this is actually from like neck sprains or neck strains, nerve trauma, keeping that head in proper alignment with the use of a weight. And then the bottom right here is an example actually of skeletal traction. It's called knee 90-90 traction. And this can be used for femur fractures. And the force is applied through skeletal traction through the distal femur. And we do want to prevent any complications during traction. So we want to, ensure that the unaffected extremities are exercised. So we want to provide range of motion techniques to the unaffected extremities. Promote the use of the trapeze to keep the patient's upper body in motion and, continued strength. Always checking for skin integrity, whether around it's the boot or ACE wraps or around the pin site. CSM checks, of course. Again, preventing contractures with range of motion. Respiratory is important, so we want to promote coughing and deep breathing, incentive spirometer, turning and repositioning the patient when they are allowed off of traction. And also think of the mind too. So, if a patient is stuck in traction for a while, we want to encourage visits from the family and friends. Diversional activities. Does a patient like to read? Do they want to watch some movies? What can we do for the patient to help them mentally? And then we'll talk about pin care. So again, this is, we want to do pin care when we have an external fixator device. It's typically used for skeletal traction. And we want to keep the pin sites clean to prevent any infection. We also do want to do pin care as well because we want to prevent healing skin from adhering to the pins. So providing that pin care, that skin will not adhere. At first we want to perform pin care weekly perform weekly after the first 48 to 72 hours. And then if there's any drainage noted earlier than 48 to 72 hours, then we can do pin care earlier. Typically, it's a mix of a chlorhexidine solution, 2 milligrams per ml, and typically normal saline. I know it says alcohol as well, but normal saline would be the choice. And using a non-shedding material for cleaning, so a nice gauze pad would work, maybe a long tip cotton swab, but we don't want to use any cotton balls, something that would really shed material. And depending on the provider's order, sometimes they want to cover pin sites with a non-shedding dressing. And that was it for fractures and then traction and casting. And let's move on to hip dysplasia, developmental dysplasia of the hip. So this dislocation can occur during a growth period in utero. The flexibility and laxity of the newborn's hips allows dislocation and relocation, so it can be typical in an infant. But it's important to remember that the hip can only develop normally if the femoral head is appropriately seated in what we call the acetabulum, okay, so in that hip socket. So hip dysplasia is developing abnormalities which include dislocation, subluxation, and dysplasia of the hip joint. So as you can see here in the picture, we have a normal head of the femur in the hip socket. And then what happens in dysplasia is the femoral head doesn't match up well to the hip socket. So it pops right out and actually relocates itself, typically above the hip socket. Frank dislocation can occur, which there is no contact between the femoral head or the hip socket. Subluxation is a partial dislocation. And dysplasia is when the hip socket is, pretty much it's shallow or it's sloping or it's flattened. It doesn't have that nice cup shape to it. So that's why the head of the femur can typically pop out of the hip socket. It can affect one or both hips. Complications of hip dysplasia. So we talked about avascular necrosis before, and this can happen in the femoral head. Recurrent hip instability, especially if this is not fixed. Loss of range of motion, femoral nerve palsy, leg length discrepancy, and early osteoarthritis. In management of hip dysplasia, so our main goal, we want to maintain the hip joint in reduction for proper development. So there's kind of three different things that we can do. So for infants younger than 6 months, they're typically treated with a Pavlik harness, and this reduces and stabilizes the hip by preventing hip extension and adduction. And then we go on to ages 6 months to 2 years, and this is when a required closed reduction is required. So this is typically done under anesthesia. This is not a surgical treatment, but what happens is the hip joint is manipulated and maneuvered gradually back together. But it's very painful to do that, so that's why it can be done under anesthesia. Sometimes skin or skeletal traction may be used first to gradually stretch the soft tissues before they do the closed reduction. And then after the closed reduction, a spica cast is worn for 12 weeks, and that will maintain the hip in reduction, okay? It'll keep the hip in that hip joint. And then an abduction brace is worn full time after the spica cast. And then, after a certain amount of time after that, then only at night. And then for those who are older than 2 years, or for those who have failed treatment, will require open surgical reduction followed by a period of spica casting. And this is a cute little baby in a Pavlik harness. And just some things that we want to do with this is we do not want to adjust the straps of this without, contacting the PCP, okay? They have to be in charge of adjusting. And it must be used continuously until instructed to take off, okay? So there'll probably be, very strict orders on how long the baby can wear it, when it can be taken off. The diaper can be changed in the harness so it can fit right under the straps. Of course, checking, skin for any irritation. We would want, a cotton onesie or a shirt underneath the straps of the harness. And typically they'll put long knee socks up so there's no rubbing on the knees. Of course, placing the infant to sleep on their back. And then our nursing assessment for hip dysplasia. So getting a good family history. Are there any genetic factors? Has anyone else in the family had hip dysplasia? It's typically more common in the female gender. And was the baby breech at birth? If they were, sometimes they're more apt to have hip dysplasia. Always, inspecting the hip, observing the hip, palpating. So we want to know any discrepancies. So when we're looking at the infant, we're making sure that the infant is on a flat surface and they're relaxed. And what we want to do is we want to look for any asymmetry in the gluteal folds, both when the patient is supine and in the prone position. So if there is hip dysplasia on one side of the leg, typically on the affected leg, there'll be a little bit more thigh rolls or gluteal folds noted. Also looking at the limb length, is there any limb length discrepancy? Is one leg longer than the other? Also noting any limitation of hip abduction. The hip should be able to abduct at least 75 degrees. We'll talk about the Trendelenburg sign, but they will have a positive Trendelenburg sign. And that's when the pelvis and hip drops when the leg is raised. So the same side as where the leg is raised, excuse me, it'll be the opposite side, I'm sorry. Noting for any clicking or clunking when moving the hip joint. And of course, looking at x-rays and ultrasounds of the hip. And this is just a video on the Barlow and Ortolani maneuvers. This top left picture is just noting leg length discrepancy, especially looking at the height of the knees. One knee will be higher than the other. The extremity with hip dysplasia will be higher than the other. This middle picture here is the Trendelenburg test. So if you see here on the left of the picture, it's normal. So when the leg is lifted up, the pelvis should pretty much remain in line. But in a positive Trendelenburg, when one leg is lifted up, the opposite hip will pop out of place. And then here's just an example for asymmetric gluteal folds or leg folds. And that is developmental dysplasia of the hip, and we're going to move on to scoliosis. So this is a lateral curvature of the spine, and it typically should exceed 10 degrees to be scoliosis. There are three types. There's congenital, neuromuscular, and idiopathic. Idiopathic is actually the most common, and it's an unknown cause, typically genetic. And then neuromuscular is from some sort of neuromuscular disorder like cerebral palsy, myelomeningocele, spinal cord tumors, muscular dystrophies. And then we talk about congenital, which actually results from an anomalous vertebral development. So early detection and early screening is key, and I know this happens, when we get our checkup every year, or seeing the school nurse, they do screening as well. So if this is diagnosed within the first 3 years of life, it's known as infantile scoliosis. If it's noted in 4 to 10 years of life, it's juvenile, and 11 to 17 years is known as adolescent. And here's just a picture of pretty severe scoliosis. And noted on the right-hand side, when the patient does bend over, when they have scoliosis, that one side of the ribs really elevates itself. And this is a nice video on the pathophysiology of scoliosis. And what happens is involved vertebrae actually just rotate around the vertebral axis, and that results in the curvature and asymmetry of the shoulders and hips. A lot of times too, is if scoliosis is very severe, the patient can have respiratory and cardiac compromise, because the the curvature is so severe. And management of scoliosis, so preventing progression is everything, and that's most important. So it's important to, of course, if there's any pulmonary or cardiac involvement because of such a severe curvature, we really need to decrease the impact on this and either get a brace on the patient or do surgery. But treatment is based on age, future growth, and the severity of the curve. Typically, we see bracing, and it may be a sufficient option in decreasing the progression of the curvature. It does not cure the curvature, but it hopefully will decrease any progression. Typically, doctors will want to do serial follow-ups with imaging just to track the curve. And then, for more severe cases, surgical correction is often required, and that's for curves that are more than 45 degrees. And what is done is actually a spinal fusion with rod placement and bone grafting. And this is that lovely picture of fixing the curve. Okay, so in picture A, it's showing you the scoliosis curve. And B, C, and D is just adding in the rods and kind of straightening that curve right out. And these are just some examples of braces. So the brace to the far right is known as a Boston brace. The middle brace is known as the Milwaukee brace, and then the left-hand side is the nighttime brace. And again, these are meant to slow progression. They don't fix the current curve, but unfortunately, too, some curves can progress despite bracing. So nursing, um, typically back pain is not a presentation of scoliosis. So, how is this noticed? Did the family notice a curvature? The school nurse? Is there a family history of scoliosis? Did the patient have a recent growth spurt? Did they just go through puberty? So getting that good health assessment, health history and assessment. And we want to inspect, right? So looking for poor posture. Um, Inspect the back in a standing position. Are there any asymmetries noted? Is one shoulder higher than the other? How are the ribs? Is one hip higher than the other? It's really important to have the child bend forward. Arms should be hanging freely at the side, and also noting for asymmetry when the child is bent over. And this is really when we can see the rib elevation to one side or the hump on one side of the back. And we would, of course, do x-rays of the spine. And more nursing. So we want to help with education and compliance, especially with wearing that brace. And it's tough with adolescent age or if it's teenage years, they really don't want to be wearing a brace. So we really need to stress the importance of this, help them with any body image, help them with what clothing they can wear, making sure the brace is a good fit, because if it's uncomfortable, they will not wear it. Is the environment good at home, good enough for the patient to be wearing this at home? So the brace should be worn 18 hours per day. We want to inspect the skin for any rubbing or breakdown due to the brace. We want to only encourage, typically during bathing is when they can take the brace off. Okay, that's really the only time of day that that brace should be off is during bathing. Make sure to dry the skin thoroughly before putting the brace back on, and again, that'll just help with breakdown. Cotton shirts should be worn under the brace to prevent any rubbing. Again, supporting the team with body image, providing maybe support systems. If surgery is needed, if they have to do a spinal fusion with rods, we do want to provide pre-op education care. So we want to make sure, that we're going to tell the client that they will be getting turned and repositioned. They should be coughing and deep breathing. It helps prevent pneumonia, and actually, by moving and turning and repositioning, we will be preventing any form of clots. Hopefully that will never happen, but it's always a possibility. What tubes or lines will be present after the surgery? making sure that they understand that we're serious about their pain management and we're going to limit as much pain as possible, hopefully no pain at all. During surgery with spinal fusions, there is actually a large risk for blood loss. So it is recommended to arrange for an autologous blood donor, so someone who has the same blood type. So when they're in the OR and if they do have that large amount of blood loss, they will have the donor bags available. Neuro checks with vital signs are important, especially when talking about post-op care. So doing the neuro checks, vital signs, making sure that's stable. Um, Log rolling technique is the only way we should be turning these patients. Avoiding flexion or extension of the back. Ugh, ouch. Pain management again. Preventing infection, especially if there is rods and pins and screws going in. We do want to provide the patient with prophylactic antibiotics. Assess any drainage at the surgical site, just like typical post-op care. Any signs of bleeding, so of course we may see it oozing out of the surgical incision. If we can't see it from the outside, we may see it from the inside by a pooling of blood or a hematoma by the surgical site. That is not good. Also vital signs. That'll show you right away if the patient's having hypovolemia going on. So they'll have low blood pressure, tachycardic. They'll look shocky. And, as following the orders as soon as appropriate, getting the patient up and walking. And then that's it with scoliosis. And we're going to talk about congenital club foot, also known as congenital talipes equinovarus. And this is a congenital anomaly occurring in 1 out of 1,000 births. So there will be inversion of the heel, which is also known as talipes varus. And then there'll be plantar flexion of the foot, also known as talipes equinis. So the heel is raised and will not actually strike the ground in a standing position. There's forefoot adduction and supination. So the forefoot is actually inverted and turned slightly upward. So really, the foot actually will resemble a head of a golf club. Half of all cases typically occur bilaterally, and this happens more in males than females, and the cause is unknown. And here's just some examples of a club foot. Really inverted inward. And there's 4 categories of a club foot. So there's postural, which actually will resolve with a short series of casting. Neurogenic, which occurs in infants with myelomeningocele. There's syndromatic, which when clubfoot is associated with other syndromes and is often resistant to treatment. And then idiopathic. It occurs in otherwise healthy infants, and again, there's no known cause. And all the approach to treatment is all the same, despite of classifications. So management of the club foot. So we want to achieve a functional foot, right? Because with that extreme inversion, the patient will not be able to walk properly. So treatment should start as soon as after birth as possible. And there'll be weekly manipulation with serial cast changes. So after weekly, then they'll go to every 2 weeks and so on from there. There'll also be corrective shoes or braces. They may need to do surgical release of soft tissue. And then post-surgery, the foot will be immobilized with a cast for at least 3 months if surgery was the option. So some complications of the club foot is residual deformity. There's rocker bottom foot, where actually the bottom or soles of the foot is rounded outward. If you think about it like a rocking chair, the foot will look like that. Of course, there'll be an awkward gait, weight bearing on the lateral portion of the foot, which isn't good, and that can lead to disturbance of the growth plate and the bone. So nursing. So we want to note, family history of any foot deformities. Was the baby in a breech position in mom? Performing active range of motion and noting an ability to move the foot into a normal position to midline. We want to inspect the foot for the position at rest. X-rays can be used to pick up any bony abnormalities. Again, if there is a cast, we want to do those CSMs, neurovascular checks, and emotional support and education. It's kind of scary for the family when their child is born like this. So just giving them a lot of support. And that is a picture of braces that will typically go on an infant who has clubfoot.